So we're good to go.
Good afternoon, everyone. Thank you for joining PHCA's for today's webinar entitled Pre-Admission Screening and Resident Review, otherwise known as PASRR, Forms and Process. My name is Abby Foster. I'm the Director of Marketing and Member Services at PHCA. We offer monthly webinars for members only for NAB-approved credits. We have over 200 individuals on today's webinar taking advantage of this member service, and we thank you for joining us. Before we get started, I have a few housekeeping items to cover. If you dialed in by phone, please select telephone and enter your audio PIN. This webinar will be recorded and made available on the PHCA website following. The webinar has been approved for NAB credit, approved by NIB for 2 credits for nursing home administrators and ALPC. Certificates will be emailed to attendees following the presentation. All attendees will be in listening only mode. If you have any questions, please use the question pane on the right to submit, and we will answer them at the Q&A portion at the end. Handouts were emailed in your registration reminder email sent an hour before the webinar, and they're also in the right-hand pane. It includes the PASRR Level 1 form, the local contacts for PASRR regional officers, and your slide deck. The objective of today's webinar are to gain a better understanding of the PASRR process and the changes made to the PASRR forms, be provided some tips on how to streamline the process when a Level 2 assessment is required, learn about the field operations review process as it relates to the PASRR requirements and acceptable documentation. This webinar will be presented by Randy Nolen, Division Director of Field Operations, and Ruth Barnard, Coordinator with the Department of Human Services, Office of Long-Term Living, Bureau of Quality and Provider Management. Ruth Barnard is a graduate of Lycoming College, and she's been the MDS OBRA Coordinator for the Field Operations Unit for the Bureau of Quality and Provider Management Division of Nursing Facility Field Operations in the Office of Long-Term Living for the last 13 years. That's a mouthful. Prior to her work with the Commonwealth, Ruth Ann spent 14 years in the clinical setting as the supervisor in a rehabilitation hospital and as a medical surgical staff nurse. Randy Nolen has worked in the public sector his entire career, first at the county level as a social worker, admission social worker, and assistant director of social services at a 400-plus bed nursing facility, and then as a program director at an ICF. He began with state government in 1994, working at the Department of Health and Family and Children Programs, then moved to the Department of Public Welfare, now DHS, in 2000. Randy first worked in the Bureau of Long-Term Care for Utilization and Management Review, and then as the Director of Medical Review in the Division of Fee-for-Services. In 2006, he returned to the Bureau of Long-Term Care, which later became the Office of Long-Term Living as the Director of Field Operations. As Division Director, Randy oversees the 7 field offices that perform reviews in all Medicaid-certified nursing facilities, which includes the MDS, OBRA, PASRR, and Financial. Our presenters are clearly qualified to present on this topic, and we thank them both for joining us today and offering this educational webinar. Randy and Ruth Ann, the floor is yours.
Good afternoon, everyone. As Abby said, I'm Randy Nolen. I'm the Director of Field Operations, and Ruth Ann's here with me, the MDS OBRA Coordinator. And what we want to do is just try to give you an overview again of the PASRR process and mainly answer any questions or issues that you have as we move forward with this. As you know, we made some major changes to the PASRR form and process. What's that? All right.
Yeah.
Okay. We made major changes to the PASRR process back in January. So what we're going to do is talk a little bit more about that today. Our objectives for the webinar is to provide an overview of these requirements for PASRR and why we made the changes. What your requirements are as a nursing facility in regards to the PASRR process. Talk a little bit about the PASRR Level 1 tool, provide you some clarifications and some updates with it. I'll talk to you a little bit about the program office's responsibilities and what their role is and what they're looking for when they review cases, and then provide you with some important websites and information on who you can call when you have questions or issues related to the PASRR process. Just so you know, a little background on PASRR. It's a requirement under Medicaid pursuant to the OBRA, which is the Omnibus Budget and Reconciliation Act of '87. PASRR itself went into effect January of '89, and it applies to all individuals seeking admission to a Medicaid certified nursing facility, which is about 630 plus in Pennsylvania, regardless of payment source, and ensures that individuals are placed in the least restrictive setting possible. It's part of the licensure requirements under the Medicaid program, and when DOH comes out and licenses you. And if you're really bored sometime, the provisions behind OBRA 89 for the PASRR process are addressed in the PA Bulletin, that was put out in December of 1988. So if you're really bored, have some fun reading that. Again, the requirements is that a nursing facility does not admit any resident with a mental illness diagnosis, an intellectual disability diagnosis, or some other related condition diagnosis which occurred before the age of 22 under the other related conditions section, unless the individual is determined through a full PASRR evaluation process to be appropriate for nursing facility services. Failure to timely complete the PASRR process may result in forfeiture of Medicaid reimbursement to the nursing facility during the period of noncompliance. And I'll talk a little bit more about that later on. So the process is prior to admission, a nursing facility must do the following. They need to ensure that the pre-admission screening level 1 tool is done. That is the identification tool that screens every individual to determine if they have a diagnosis either under the MI program, intellectual disability, or other related condition. And if they're found to have a qualifying diagnosis, then you have to ensure that the pre-admission screening evaluation tool, which is a level 2 tool, is done prior to admission. And then once that tool is done, then you need to have a program office letter of determination from one of the 3 program offices that review these cases. There's a program office under the Office of Mental Health and Substance Abuse. There's a program office under the Office of Developmental Programs that reviews the ID cases. And then in the Office of Long-Term Living, the other related condition cases are reviewed. A little bit before we go into the form itself, because we're going to go through the form fairly quickly because you guys have seen it for years, plus you've seen this version of it since January, and you've been working with it. Just to give you a little background of where we're at with this, we do realize that there was major changes in January to the process or to the form. The process itself hasn't changed. It's still a requirement under the OBRA Act. It's still mandated that it needs to be done prior to admission. Its purpose is still identify individuals that have one of the 3 potential diagnoses under the category, and it has to be done prior to admission to assure that they're being appropriately admitted and to determine whether they may need any other services that aren't normally part of the nursing facility services, and an ability to try to maintain their current condition or improve their current condition with the goal of trying to discharge them back out to community living. Over the years, when this process first started, CMS was heavily involved in it back in the late 80s, early 90s. It was a mandatory, it's a mandatory process. They were very involved in it. And there was a period of years where there wasn't a lot of changes to it. There wasn't a lot of discussion about the PASRR process. And then probably, it's about 8 years now, CMS finally realized that the PASRR process is one of the, or is the last process that they have in place to ensure that they're meeting ADA requirements when they admit people into nursing facilities. So it's an ability for CMS to make states aware of the process and to ensure that we're just not putting people in nursing facilities without looking at alternative types of care or services that they may need. So that was one of the big things that CMS decided. And then at that point, they started doing reviews of all states' tools. And the first year that they did that review, basically what they did is they just went to each state's websites, pulled their tools off, and then did an evaluation on their tools to see how comprehensive they were in meeting the federal requirements. Unfortunately, it's not easy to find stuff on Pennsylvania's website sometimes. And back then it was even worse. So they didn't find all the tools, and then one of the biggest things they didn't find was the level of care determination, or it was the LOCA back then, the assessment tool that was done on individuals. So we were rated below average on everything. And in the first report that came out, we were actually rated in the lowest 25 percentile, and we were actually mentioned in the same sentence in the report with Washington, D.C., which is a terrible thing to be coupled with them. And hopefully there was some laughter on that. So we realized over the years that we needed to make some changes. We need to educate CMS on our process, and we needed to make some changes, and we did. We changed the form about 6 or 7 years ago, and then we changed it again in 2014. That's the spring of 2014 is when Ruth and I traveled across the state and did a number of trainings, in-person trainings on that form. I was hoping at that point that we were done. Obviously, that didn't happen because CMS has basically come back year after year and done a report. Now, we've moved up steadily. We're in the 75 percentile right now, and hopefully with the new tool that we put in effect in January, that will move us up into the top tier as far as being comprehensive of what we're looking at and meeting the requirements of the regulations. Unfortunately, for the states, it's been a lot of changes over the last few years. CMS is now emphasizing specialized services a lot more. They expect us to be able to provide the same type of services to individuals in a nursing facility as they were provided or available to them in the community. So there's a lot more expectation that we're able to provide those services to these individuals. So we worked over the last couple of years both with the Office of Mental Health and Substance Abuse and the Office of Developmental Programs to identify services that they provide out in the community that should also be provided to an individual in a nursing facility. And as you know, if you look at the Level 2 tool, those potential services are actually listed on the tool. Other related condition program for the last few years have had their services identified. But we just worked with this new tool to get ODP and OMSOS to identify their services. So that was one of the newest emphases with CMS. And a lot of that was changed in our last tool. The biggest thing that precipitated the change in January with the new tool, and it took us about 10 months to work on this and get it through the system. And we worked extensively with the program offices, with PTAC, which is the PASRR Technical Assistance Group that works with, that CMS subcontracts with to work on PASRR related issues, and with CMS directly to make the changes to the tool. What they basically told states about a year and a half ago in their last report is that all states were too restrictive on their Level 1, the PASRR ID tool, and that we were restricting the potential to have people get a Level 2 evaluation done in an attempt to determine whether they would benefit from specialized services. So they necessitated the changes to the tool at that point in time. What they basically told us was that the regulations strictly apply to the Level 2 evaluation tool, that they really don't apply to the Level 1 screening tool. So that any restrictions that we had on the Level 1 tool, we needed to remove. And you'll see there's some of them are still in the Level 2 tool. Some of the time frames are still in the Level 2 evaluation tool, but that's because that's part of the regulations. But they told us we were too restricted on the Level 1 tool, so we had to take some things out. So in the past, I mean, to be a potential person who needed a Level 2 evaluation, you needed to have a diagnosis and then meet a couple other criteria in different categories. We've had to change the tool that if you have a serious mental illness diagnosis, even if you don't have areas checked in other areas or something checked in other areas, you still meet the criteria to have a Level 2 evaluation done. And we're tracking with the program offices how many evaluations are being done. We know that we've had an increase of about 300%. In regards to this, this has created a burden for the program offices. It's created a burden for the AAAs. It's created a burden for field operations, and it certainly has created a burden for nursing facilities and hospitals. So we're trying to address some of those issues that we have with that. We did that in mid-February. We put out a clarification and Q&A document, and we'll talk a little bit about that after we look at the form to try to clarify some things, especially around depression and anxiety and neurocognitive disorders. We tried to clarify some things, so the hope is that we will alleviate some of those cases that need to have a Level 2 done. But we realize there's still a lot of questions and concerns as we work through this process, and we're working closely with various nurse facility associations. That's, and I appreciate the opportunity to come and speak to you today. We've had meetings jointly with HAP and with FCA in regards to things. I've done some webinars at HAP also as we try to educate hospitals in regards to the process also. So it's a multi pronged type of attack we're trying to take to try to smooth the process out a little bit. Unfortunately, some of the stuff that we'd like to do, our hands are tied by CMS. So there's only so many changes we can make in regards to this process. So what I'd like to do, with that little bit of history and background, is go ahead and have Ruth Ann go through the form. We're probably going to spend the most time on the first section, which is the mental illness section, because that's where most of our questions have come in, is under the mental health side. So.
Okay. So we're not going to go through each line item on the form. We're just going to do some of the highlights. So everybody knows about the demographics. That's a given. The section 2, neurocognitive disorder, dementia area. I want to talk a little bit about this. Lots of people have dementia, neurocognitive disorders in your facilities. You're seeing it more and more. And if a person has a major neurocognitive disorder, those are the folks that are going to be a regular admission. If you have a major neurocognitive disorder, you will not most likely have to go and do a level 2 process for those folks. Okay, we have the screen back up. Sorry about that.
That was my fault. I shouldn't touch computers.
And actually, I'm going to back it up to, there we go, neurocognitive disorder, dementia section. So a major neurocognitive disorder, and it may be Alzheimer's, it may be a traumatic brain injury, it may be Huntington's disease, those kind of things. If you have a major neurocognitive disorder, those are the things that are not going to need a level 2 assessment done. Okay? So if you have a mild neurocognitive disorder and you have some of the mental health disturbances as a result of the dementia, and the same with the major dementia. If you have some of the psych problems or things happening because of the dementia, they're going to a geri psych unit, they're being placed in a hospital psych unit. Those are the kind of things, it's a result of their dementia process. So we're asking you to look at what's going on with the individual, okay? Don't look at the ICD-10 diagnosis codes, because that's not going to help you figuring out what's going on with the individual. You need to look at what is actually going on, what is written in the chart, what the physician is saying about their dementia or neurocognitive disorder diagnosis, that kind of thing, okay? And see if the mental illness behaviors are a result of the dementia diagnosis. So we're asking you to do some work here. So that's one thing. When you get to the number 1 in section 2, you need to be able to tell, is it mild or major, okay? And if it's major, those folks, we don't want to send through a level 2 process. So that's easy. They're going to go in as a regular admission, okay? And then if the physician has indicated a level for the neurocognitive disease process, you need to enter it, mild, major. And then at 3, add more. You know, we want more information. Was there any testing done? Was the diagnosis actually given by a psychiatrist? Was it given by a psychologist, or was it by their PCP? All of that's important information to know. So we ask you to enter that, okay? Any kind of notes regarding their diagnosis, put them on this page, okay? So if their behaviors are a result of the dementia or neurocognitive disorder, put them down, okay? So anything that will help us to work through this form, make a note of it, okay?
And one of the clarifications we put out in regards to neurocognitive disorders, we said, a person has severe dementia, Parkinson's, Huntington's, etc. They're unable to take care of their daily needs and their mental status is such that they would not understand or benefit from specialized services, then this would override their serious mental illness and they would not need to have a level 2 evaluation done. So even in that area where you're not sure if it's mild or major, then take a next look and see what the chart documentation is. And if their condition is so severe that it outweighs their need for specialized services or the ability to understand specialized services, then they have a severe dementia or a severe neurocognitive disorder, and they do not have to have a level 2 done. So that was one of the clarifications we put out in February.
Yeah. So I'm going to continue on here to section 3. Yeah, that's a good idea. Section 3, the serious mental illness section. Just a note on the side, the PASRR level 1 tool has been made user-friendly on the website under the MA Forms on the MA Forms website. So now you can actually fill it out online and save it electronically. So that is an option to folks in case you were not aware. So for the serious mental illness section, we ask obviously for the diagnosis. The serious ones are major mental illness diagnoses would be your schizophrenia, your bipolar disorder, your major depressions, okay? Minor would be your mild depressions, your anxiety, your simple anxiety, those kind of things. So we're asking if it's a mild diagnosis, such as a simple anxiety, minor depression, not major, that you mark no, okay? And then for your majors, we're asking you to put yes there for the diagnosis. The major mental illnesses do have to go to the program office now. That they need to be seen by the program office to see if there's anything that can be given to them to help them with their major mental health diagnosis. Okay? We put out a clarification document on this.
So I'll talk a little bit about that. So in our clarification document, we put out 8 clarifications. 4 of them have to do with this question. So I'm going to go through those with you because there was a lot of confusion and concern and a lot of cases being sent in because you couldn't tell the difference between mild or major anxiety or depression. And one of the issues that occurred was the issue in regards to the ICD-10 codes, which for some reason list everything as major depression, and that's the codes the hospitals have to use to be able to get payment for that service. So that's the first clarification I'll talk about. Mental health diagnoses resulting from an ICD-10 billing code are not always as reliable and accurate as a diagnosis determined by a physician based on information in the DSM-5. That is why it's always preferable to clarify diagnosis with the physician, because if you go by just that billing code, you're going to have everybody listed as a major depression, and these cases were all being sent in, and they were holding up admissions, and none of them were coming back as potential targets because they all had mild depression. So let me walk through the other 3 clarifications we made. On major depression, we worked with OMSOS to take a look at that. They talked to their psychiatrists on staff and got some clarification out of the DSM-5 to clarify mild versus major depression issues. And what they tell us is an individual has a major depression if they meet the following criteria. They have to have 5 or more of the following symptoms had to be present during the same 2-week period and represent a change from the previous functioning of the individual. At least one of the symptoms is either a depressed mood or a loss of interest or pleasure. So there has to be one of the 5 symptoms. One of those 2 have to be one of the 5 symptoms. And these have had to occur within a 2-week period. The 9 symptoms that you're looking at is they have a depressed mood most of the day, nearly every day, as indicated by either a subjective report or observation. 2, they have markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. 3, they have significant weight loss when not dieting, or weight gain, or decreased in appetite nearly every day. 4, they have insomnia or hypersomnia nearly every day. 5, psychomotor agitation or retardation nearly every day, observable by others. 6, fatigue or loss of energy nearly every day. 7, feelings of worthlessness or excessive or inappropriate guilt, which may be delusional, nearly every day. 8th symptom is diminished ability to think or concentrate or indecisiveness nearly every day. And the 9th symptom is recurrent thoughts of death, not just the fear of dying, but thoughts of death, a recurrent suicide ideations without a specific plan, or a suicide attempt, or a specific plan for committing suicide. So to be considered an individual with major depression, they would have to meet 5 of those 9 symptoms within a 2-week period. So even though you're getting stuff coming through that has an ICD-10 code listing them as major depression, look deeper before you send them off for an evaluation. If that person is alert and oriented, they're participating in their care, they're cooperative, they're interacting with staff or other individuals, they're feeding themselves, they're eating a normal diet, they're trying to take care of themselves, they're not going to meet the criteria of major depression. So you take them into the facility. I mean, what you have to understand is most people we're looking at, that you're looking at, are at a point in their lives where they're losing loved ones, family, independence. Now they're facing going into a nursing facility. They're all going to have mild depression or anxiety because of their change in condition, their change in setting. It's a normal part of the process. Now, if you get an individual in that you feel is mild and they're in your facility and all of a sudden they don't adjust well and they start exhibiting these symptoms, then you can do a change in condition on them. But look at them upon admission. If they're functioning and they're in the hospital for a week and, so go back 2 weeks, how were they functioning at home? If they were interacting with people and they were social and they were trying to take care of themselves, they're not going to have a major depression. So you really need to look deeper than that ICD-10 code. The other part of that, besides having the 5 or more symptoms, the symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, and the episode is not attributable to the physiological effects of the substance or to other medical conditions. So you're really taking a close look at those. The other clarification on major depressive disorder is when it's been diagnosed as a single episode in the past. In the past, OMSOS considers over a year ago. So if they had a single episode 3 years ago, their spouse died, so they went through a 6-month period where they just weren't functioning, they weren't capable of taking care of themselves, they were really down in the dumps, they didn't interact with anybody, they weren't eating. So after a 6-month period, they start to rebound, they start taking care of themselves, they come back and were functioning in the community. If it was more than a year ago and it was a single episode, they don't need a level 2 done. Okay? Then on the anxiety issue, anxiety should only be considered a serious mental illness when it's persistent and causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. Basically, you're looking at somebody who is scared to go out of their house or scared to talk to anybody or can't function if you move them from one room to another room. They're so anxious that they're nervous and they think everybody's out after them and they just can't take care of themselves because of that anxiety. that would be a major anxiety that would have to go through a level 2 evaluation process. So, I mean, the hope is we put this clarification out in close to the end of February. The hope is, in our discussions with OMSWAS, is they're seeing a marked decrease in the phone calls, asking them questions about this, and they are seeing a decrease in the number of cases that are coming through them. We track stats on a monthly basis on the number of cases that we review to the program office, how many of them come in, and then we find that they're not a target, and how many of them come in and do need specialized services. So we do track a lot of data in regards to this because we're trying to alleviate some of these cases where it's been really tying up the system by having them all evaluated. So that's kind of the clarifications on the mental health or the mental illness side, especially around the dementia and anxiety situation. So, like I said, you know, we put out 8 clarifications, and we're just on the third section of the form, and we've talked about 6 of the 8 already. So this is where our major issues and emphasis was. So what we'll do is we'll go ahead and continue back with the form on substance-related disorders.
Okay, substance-related disorder, you have to realize that just because they have abused a substance does not make them, or does not mean that they need to have a level 2 assessment done. This is kind of an independent question. So just because they do have a substance-related disorder does not mean that they need to have a level 2 done. They must meet other criteria in addition to the substance-related disorder in order to meet the criteria. So we're just simply asking if they do have a substance-related disorder and what the substance is, and are they needing nursing facility placement because of the substance-related disorder. Some folks, and it has to be because of the substance-related disorder. So, for example, an individual that has smoked a large part of their life and now has lung cancer, and they need placement because of the lung cancer, that would not mean that they have a substance-related disorder that would need nursing facility placement. So it's not associated with the diagnosis. They need nursing facility placement because of the cancer, not because of the substance, although the substance related to that. I understand that, but it's not the reason that they're being placed there. Now, somebody that overdosed on, say, cocaine or something like that and ended up going to the hospital, ended up in a coma or depressed state because of that, and needed to go to a nursing facility to get back on their feet, that would be related to the nursing facility placement. So it has to have a link there.
Two things on this. The reason the question is being asked is CMS feels that if somebody has a substance-related disorder, they want us to look a little bit closely at that person to see if there's a potential underlying mental illness. A lot of times there is a link between the two of them. So that's the reason why CMS has required states to ask the question. The second thing you have to realize is even if you have a yes in this section, if you have a no in the first section, that they have no MI diagnosis, this does not, they don't have to have a level 2 evaluation done. It's not an automatic. This is more of an informational question and a process to try to get individuals to look more close at that person to see if they have an underlying mental illness.
Yeah, and oftentimes they will have something else going on. So in Section 3B, we oftentimes people with substance-related disorders will have a check in one of these boxes, but not all the time. So substance-related disorder is really independent of the rest of the mental health section, although there are relationships there. So in Section 3B, we are asking for some of the things that are going on with an individual that has a major mental illness diagnosis. Oftentimes those folks will have something here checked, such as such as being in a psych hospital at least once in the past 2 years. So those people with a major mental illness will have that, perhaps, as well as maybe a case manager, seeing a psychiatrist, may have received ECT, could have been in a state hospital situation. So those with a major mental illness could have some of this significant life disruption as well, like a suicide attempt or ideation. There may be some legal or law intervention that has occurred. Remember, it's for the serious mental illness, loss of housing, life changes, those kind of things going on that would, by being checked independently here, it would mean that they would meet the criteria to have a level 2 assessment done. Now, some of this stuff may be checked for a mild mental illness as well. So in both cases, if there's one check marked a yes in section 3B, anywhere in 3B, either 1 or 2, that would meet the criteria to go on and have a level 2 assessment done. So the reason to do a level 2 assessment, let me just go back. You must have a major mental illness. Okay, so 3A1 would be marked a yes. So that by itself would meet the criteria to have a level 2 assessment done. Another way to meet the criteria is by having a yes marked somewhere here in 3B1 or 2. Okay, so significant life disruption, anywhere a yes, and anywhere over here in number 1, such as treatment for your psych problems, such as a hospitalization or a psych program, like a day treatment program, ECT, any admission to a state hospital. So that would meet the criteria, as well as major mental illness. And you may have both together, and that would also meet the criteria. So, okay, let's see here. Yep. And then we do ask for the level of impairment, but we have changed this question a little bit for this update. We need at least one of the following, or we're asking if they've had at least one of the following. This is an independent question and does not feed into whether or not they meet the criteria to have a level 2 assessment done on this form. The level 2 process is a little bit different. It gets more stringent, and it's less of a look-back period for the level of impairment. But on this level 1 form, we're just simply asking you the question and you check the box. And then once again, I did stress this is your note section saying what does meet the level 2 criteria. So there's 3 ways to do it. You can have a major mental illness. So you would have a yes in 3B or 2B number 1, and you would another way. The second way is by having a yes somewhere in 3B, and the third way is by having both, something marked in 3B and something in 2A. 2A. Yeah, 3, section 3. Sorry. 3A number 1. Okay.
Like I said, in the past, before January, you'd have to have something marked in each one of the sections, or at least 2 of the 3 sections. To make it less restrictive, based on CMS guidance, we made it that if you have something marked in either one of those 3 questions, that it makes them eligible and appropriate for a level 2 evaluation to be done. So that's one of the changes we made to make it less restrictive.
Okay. Okay, yeah. Okay, so let's go on to the ID section. There's not been as many questions here because this section really didn't change much. We're still looking at whether or not there is a current evidence of an ID or an ID diagnosis. And it can be mild, it can be severe or profound, and just simply yes or no. And then we need you to list the diagnosis or the evidence of the diagnosis. And then we did change, the one change we did make to this updated form is, did the condition occur prior to the age of 18? The form prior to, that we used back in December actually was the age of 22. So we brought it down to 18 because this is the age that the federal government uses, CMS uses, as a starting, or the last, the age. Then we also ask at 4C, we ask if they have something other than a mental illness that could result in impairment of functioning. So we're looking at the function here. And if they do, we want to know what it is. Okay. One thing we did change is that one of the criteria that can be met for an intellectual disability is that they only need to have one of these functional criteria checked. They must also have the diagnosis, and it had to have occurred prior to the age of 18. Now, supporting information for ID, we ask if they've been registered with their county for any kind of ID services. If you know that, we ask that you mark it down, what county, what agency, name of supports coordinator, if they had one, and was the individual referred for placement by an agency that serves ID individuals. And then, has the individual ever been a resident of a state facility, state hospital, state-operated ID center, gone to a state school, or anything like that? We ask you to note that as well. And then the note section, once again, now on the form is going over the criteria that must be met in order to have a level 2 assessment done. And like I said, the individual must have evidence of an ID or an ID diagnosis. So at 4A, you must have a yes. The individual has evidence of and determine that you have to have one functional limitation as well with that. And the individual has some kind of supporting documentation, whether they went to a school or they received services from the county, that kind of thing. That's another way, just by itself, that they can meet the criteria to go on and have a level 2 assessment done. Okay, other related conditions. This section as well wasn't changed a whole lot. The major thing is that in 5B, we no longer require them to have 3 of these functional limitations checked. They can just have one of them checked along with the diagnosis that manifested prior to the age of 22. And then they would meet the criteria to go on and have a level 2 assessment done. One thing I want to mention here is that sometimes you have a crossover with a neurocognitive disorder, such as your traumatic brain injury people, but note that if they had a traumatic brain injury prior to the age of 22, they could also meet criteria for another related condition. So just be aware of that. If you have a neurocognitive disease marked a yes, you're not done with the form. You need to continue to this and fill out the rest of the form, because they could also be a yes here in the other related conditions section and meet the criteria, depending on how severe the traumatic brain injury was or the neurocognitive disorder. So just be conscious of that. You may cross over sections here with your ORC. It's one functional limitation and a diagnosis prior to the age of 22 that would meet the criteria for a level 2.
Yeah, we're no longer looking for a diagnosis after the age of 22. That was on the old form. We're just concerned with anything prior to the age of 22, so that's when a diagnosis had to be made. So if they developed epilepsy or MS in their 40s, they do not meet the criteria.
And you do not need to put the diagnosis on this form in this section. And the home and community services, that's just informational gathering questions.
All right, here's one of the sections that causes a lot of issues, the exceptional omission section. There's, by criteria, there's 4 exceptional omissions that will allow you to bypass the level 2 evaluation process, but you must meet all the criteria of these exceptions. It's your responsibility to make sure that they truly meet the criteria. So the first question is, does the individual meet the criteria to have a level 2 assessment done? So that means they have a diagnosis or a treatment concern under either mental illness, intellectual disability, or other related conditions. So they meet the need for a level 2 evaluation done. So that's the first thing. Are they a safe individual, so they're not a danger to themselves or others? And then they must meet all the criteria for the exception. So that's the first question you ask. And if it's no, then you skip to Section 8. If it's yes, then you work through the exceptions. The first exception is an individual is exempted hospital discharge and must meet all the following prior to going into the nursing facility. So there's basically 3 criteria. They are currently, or they are being admitted to the nursing facility from an acute care hospital after receiving inpatient medical care. It's strictly inpatient care at this point. Not observational stays, not from an inpatient psych or behavioral health unit, not from the ER room. It's strictly an inpatient stay. And I do realize we've had discussions with HAP about this. It is an issue. But until CMS is willing to make decisions on what they want to do with observational stays, which affects both the PASRR process and your 3-day stay Medicare criteria, I can't exempt those people in. The second thing is they need to require the same services in the nursing facility and be treated for the same thing they were treated for in the hospital. They fall and fracture their hip, they need therapy to go back home, they're being treated for the same thing. If they're in the hospital for pneumonia and they're deconditioned and they need to go through therapy to strengthen to go back home, you're treating them for the same thing. If they were in the hospital because, I don't know, they had some episode, but you're treating them because of their cancer or their diabetes or something like that that was unrelated, then they don't meet the criteria. The third thing is that the hospital physician must certify the individual is going to go back home after 30 days and that they are a safe individual to be discharged to the nursing facility. So all we're asking for is a note in the hospital chart. We've talked to HAP. They can put canned language in there that says, we feel Mr. Jones will return back home within 30 days or less of nurse facility care, and he's safe to go to the nurse facility and then return back home. As long as you have some type of language in there, the physician signs off on it, that's fine. The change we made is we used to have the physicians sign off on the PASRR form. We weren't able to get the physicians to sign off on it. So we thought it'd be easier if they just put a note in their medical record and it's there for you when you get the medical record from them. So they have to meet all 3 of these criteria to be a hospital exemption.
And we asked that the documentation be with the PASRR on your chart.
Yeah, so I mean, if you got that doctor's note that says they're going to be there less than 30 days, just make a copy of that, put it with the PASRR, and keep it on the medical record in the same spot. That way, when field operations comes in to review it, we can see the documentation you were using. The other 3 exceptions are fairly easy. An individual comes in and requires respite care of less than 14 days. You don't need to do a PASRR 2. Individual requires emergency placement. These are your cases that come through protective services. Or an individual's in a coma or functions at a brainstem level. You don't need to have a level 2 done. Now, in the process, what happens after you meet all these criteria for the exceptions, but what happens if they're in there for a while and they no longer meet the criteria? So your hospital exemption is there more than 30 days. Say they came in with a fractured hip, they fell and fractured the other hip, so they're going to be there longer. Or the person's no longer under protective services, or they're in for respite care and now something happened to the caregiver and they need to be there longer or admitted long term. Or you get a person who was in a coma that after 3 years gets up and starts walking around your facility. Yeah, Gail's laughing, but it happens. I had one after 5 years that came out of a coma, and we got him out and discharged him within a year. It was one of the most amazing cases I worked on, but so it does happen. So the process is, if you have a change in condition like this, you do the 408 form, you send that in to field operations, and we will work, and most likely field operations will come out and do the level 2 evaluation on the individual. Now, if MA still needs to be turned on, then AAA will do the evaluation. But there is a means to handle that as long as you have all the documentation. So if you know within the first 15 days that they're going to be there more than 30 days, go ahead and send the 408 in and let field operations get out to see them. Because the bottom line is we have to have everything done within 40 days. So if you wait 30 days until we get the evaluation done and all that, we're pushing the 40-day limit. So if you know at day 15, day 20, the individual is going to be there longer than what their exception is, then go ahead and let us know on the change of condition.
And the signature there is the nursing facility staff signature. That is the signature. A lot of times the hospitals are messing that up and thinking the physician signs there. This signature line is for the hospital or for the nursing facility staff to indicate that a change in exceptional status occurred. So.
And if they signed off on it, then you just sign off underneath it.
Yeah.
That's fine. So that's the exceptional admission process.
And the screening outcome, that's pretty self-explanatory by this time, I'm sure. I'm not going to go over that. And your signature blocks, that's I'm sure you're aware of all that by now as well.
So just what I'll do is go over a couple more slides about process with the program office, and we're going to pull up the clarification Q&A document, and then we'll answer questions based on that. Just a couple things. What happens if a program office criteria is met? Well, if on the PASRR ID level 1 you meet one of the criteria for one of the 3 program offices, you need to forward that to, I mean, we're telling the hospitals they need to forward to the AAAs to make sure that people get evaluated so that the PASRR packet can be put together and sent to the program office. The entity completing the PASRR EV must forward the evaluation to the program office. It's either the AAAs or field operations. Nothing has changed in that process of who does it. The AAAs will do it if they're still out in the community. The AAAs will do it if the person's in the nursing facility and needs MA turned on, or if they've been in the nursing facility for a while, then field operations will come out and do that. And field operations will usually coordinate that with the AAAs to make sure the right entity is getting it done, or that we're getting it done so that you can get your MA payment. Process for the level 2 assessment, again, the area agency on aging in the county you're in does the level 2 assessments. It's the county that you're in. It's the county that the person's in the hospital in, not the county they came from. So if the person lived in Dauphin County and they're in a hospital in Cumberland County, it's Cumberland County's AAA's responsibility to do the PASRR process. Some of the information needed for the AAA in order to do the assessment, they need an MA51. They should be getting that from the hospital or the physician. They need a level 1 form. They need a number of things from the chart: physical exam, history and physical, med history, doctor's notes, nurse's notes, anything that's done with therapies or any other types of consults that will help us make the decisions on whether they meet the criteria. So those are the types of information that they need.
And field operations will be asking for similar information.
Yeah, if they come in, we will provide you with a list of the stuff that we need for you to copy off the chart so we can do the packet. Then the packet is put together and sent to the program office. They review all the information to determine if the individual meets the criteria. For an individual that needs a level 2 assessment done, it is the program's office responsibility by federal regulations to make the following 3 criteria: whether the individual meets the criteria for the program office, whether they meet the criteria to be eligible for long-term care and nursing facility services, so they're NFCE, and then whether they meet the need for specialized services and what those specialized services could potentially be. From their review, they provide you a program office letter of determination. You do not have to wait for the actual letter to be in your hands to admit somebody. You can take a verbal okay from the program office. Just document who you talked to and when, and that they gave you a verbal approval to admit the individual. Nursing facilities, you can do that. Hospitals cannot. And we've told the hospitals that if they want a verbal, they need to bug the nursing facility to get the verbal. So that certainly will cut down on some of the time process for you. Some other things we're trying to do is cut down on the time, is we're making the forms electronic to be filled out. We are trying to set up all the systems up so that packets are being set electronically. We are finishing that process up with the Office of Developmental Programs to make everything electronic so that we can move this stuff a whole lot faster than what we've been able to in the past. Because the understanding is that by federal regulations, there is a time window of 7 to 9 days for this full process to be done. So that's from when you identify them as a potential individual who meets the criteria of a program office on a level 1 tool to getting the evaluation done, the evaluation to the program office and reviewed, and the final letter of determination. So from identification to final letter of determination, it's a 7 to 9 day window. So we're looking to change some things with that and with our assessment process to try to meet that criteria so we're not stretching these things out longer than that. I mean, my hope is to get them done in 3 to 5 days. One of the things that we talked to the hospitals about were assuring that if they got individuals that come in that they think could possibly need to go to a nursing facility, that they need to start the process ASAP. Even if they do some paperwork and the person goes back home, it's a lot better to start the process and get it done, or at least start it, instead of waiting until the day of discharge and then realizing, oh, I got to go through this 7 to 9 day process yet. We put up some important websites. The first one is how you order your MA forms. The second one is a lot of information about OBRA and where the forms are at. And then the third website is some information about long-term care services in general. There's a lot of information on there about health choices. It's always a good website to go and look up stuff. So there's a lot of different things you can look at. So I'm going to let these websites up here for a little bit. Let me see what other slides we have. The PASRR clarifications Q&A documents is on the, we gave you the website for that, and that's where the PASRR bulletins and trainings are from that, and then also information about who the field operations are and the program offices are. Anything beyond that?
No,
all right, we'll come back to this. We gave you Ruth Ann's information and my information. So I'm going to leave these websites up here, and I'll switch to the next website then in a couple minutes.
Actually, are you able to?
Are you able to pull up the Q&A?
The OBRA training website, I think we have a snapshot of it here, or soon. Okay, there we go. That's actually what it looks like going into it, and as you can see, the PASRR clarification question and answer document is right there on top. and you just simply click on it. It'll take you to the document. On that website, we have the forms can be found at the MA Forms website, so that link is there as well. That is where you would find the MA 376 form. The 376 is your level 1 PASRR tool. So you would just simply scroll the MA Forms website to find the 376. And you would download it, and if you want to fill it out electronically, that's where you would actually fill it out, and then and do a save as on your computer, and you can save it for that individual. And then if you need to print it, you'll have to print it out to put it on the residence record, but you can do it that way, or you can, as always, you can always order them online at that website as well. So
I think what I'd like to do now is go through some questions and answers that you have. I mean, I'm not going to read through the question and answer document that we have because it's 20 pages long and it's kind of tedious to read through. I went through all the clarifications. One of the questions that came up, and it will tie into something else that I want to talk a little bit about. What should a nursing facility do if the resident is admitted to a nursing facility and after reviewing the level 1 completed by the hospital found it to be inaccurate and the individual actually required a level 2 assessment? This may happen in a number of different ways. The hospital may just not tell you that the person had the diagnosis because they want to get them out. I did not say that in the joint meeting with HAP, but it does happen. Or, I mean, there's a lot of times where you may not know the information. They're admitted to the hospital for something, and they do have a mental illness in the past, and it just didn't get documented. The family didn't say anything. The hospital didn't know the individual. It does happen, and then you admit them, and then you do the history and physical. You talk to the family and find out, hey, mom was diagnosed with schizophrenia 30 years ago. And now you realize, all right, I need a level 2 evaluation done. What you do at that point in time, you just send the change in condition 408 into the field operations office, and then we'll work back and forth with the AAA to determine who will come out and do the evaluation. There's nothing more you need to do than that, as long as you notify us so that we don't find it upon our review. And we'll work with the AAAs. If the person needs MA turned on, they will come out and do it, so they can do the paperwork for the MA application at the same time. Or if they're non-MA, we'll come out and do it. Or if they're already on MA, we'll come out and do it.
right, and
So that's not a big situation. It does happen a lot, and it's not, we have a process in place to handle it. Just document on the PASRR form itself. There's plenty, this document is a breathing, working document. Write on it, document on it. So if you go through, just make a note on the bottom of the form. You know, upon doing Mr. Jones' history and physical and talking with the family, we found out he was diagnosed with schizophrenia 20 years ago. We now feel he needs a level 2 evaluation done. We are going to refer this to field operations through a 408 form, sign and date it, and that will cover you that you found this potential targeted individual, and you'll be good with that situation. So we'll look at that. And let me talk a little bit about, because I mean, I know this is a conversation I had with Gail and some other folks that came in for a meeting, is, you know, I talked earlier, if the PASRR process isn't done in a timely manner, we will be looking at non-payment for those individuals, stays while they're there. I didn't do that to scare nursing facilities. I did that because it's part of the federal regulations. But I also did that because we have some nursing homes that will look at field operations when they come in and say, we're admitting whoever we want to, and there's nothing you're going to do to us about it, so we face no sanctions or penalty on it. What I'm looking for is to catch the individuals that are doing that. I mean, if you take somebody and you didn't know that they were a target and the hospital didn't provide you the information, I'm not going to penalize you for that. We're going to look at all these on a case-by-case basis. And if I find, if we find the documentation was there, you knew they had a mental illness before you admitted them, you omitted them anyways because you didn't want to wait for the PASRR to be done, then you're running the risk of being sanctioned and not paid for the amount of time that the individual's in there. But before we move forward with that, I want to, the process we're going to go through at least until July, or depending on how we get things straightened out here as far as getting all these documents clarified. I'm not going to look at penalizing anybody now. I want to get people comfortable with doing this process with the new forms. But we'll look at it on a case-by-case basis and deal with it from there. I will be putting a process together that I will send through PHCA and other associations to make sure that they have a good understanding of it before we start doing anything like that. I'm not looking to be punitive in this process. I'm looking basically to protect what the state has to do and also to protect the state if CMS comes in and does review of our PASRR process and finds that we're not making nursing facilities adhere to all the regulations. Because what they'll do then is they'll take money back from the state, and that becomes a major issue at the state level. So I think the cases are few and far in between, but I just wanted to deter the facilities that may possibly be doing this and either doing it because they want to admit people or doing it because they don't fully understand what their process is that they have to go through. So I'm not going to be out on a witch hunt trying to take all the money back from you, and so don't overly be nervous of that. But I just have to adhere to what our regulations are with that. Some of the other questions, what do you mean by specialized services? If you look at the PASRR 2, the level 2 evaluation form, the specialized services are listed under each program office.
And this is not a form that nursing facilities fill out. This would be something that field operations or the AAA would actually fill out. But they may ask you about the specialized services if you are actually working with them.
So if you look on the form that we sent you on page 3 of the PASRR EV, we list the specialized services for the mental health system.
I don't think we sent this.
Okay. We may not send the EV to you, but if you can pull it off the website.
In the right-hand side of your pane, you'll be able to find the handouts, and this is listed as the PASRR form.
No, no.
No, this is the PASRR. This is the 376.2 PASRR form. Okay, I think the one we sent you is the 376, which is just the ID form.
Yeah.
But the specialized services, you're asking about those, they're actually listed in the PASRR EV form. So if you want, you can always go and click that form and take a look at those specialized services. What happens is when the PASRR EV is filled out by the AAA or by field operations, we will put recommendations on there to the program office of what specialized services we think the individual may benefit from. And when field operations are in, they may talk to you about it and say, do you think Mr. Jones would benefit from this, this, and that? So that's part of the evaluation process.
But, if you're really interested to see what they are, you can certainly, by all means, that's on the OBRA training website. That is one of the forms that is mentioned there, and it can also be found right underneath the MA 376 form. But we did not include it in this training because nursing facilities, you don't fill it out. So.
All right, next question is, if they have a major neurocognitive disorder, would they ever need a level 2? If they have a major neurocognitive disorder that meets the clarification that I gave you, which basically stated that they're unable to take care of their daily needs and their mental status is such that they would not understand or benefit from any specialized services, then they would not need a level 2 done. And once you've got a major neurocognitive disorder, you're not going back, so you're not going to ever need a level 2 done. Do we still need to list if there is a diagnosis of depression or anxiety on the line if it is a mild? No, you don't have to list mild or mild anxiety or mild depression on the diagnosis line in 3A.
Yes, you should. You should.
You don't have to, but it's an informational piece that will provide information. But you're going to check no. But you can write there that they have a mild anxiety or mild depression because it provides information when we take a look at the form. But make sure you check no so that you know you don't have to do the level 2. All right, this print's getting smaller. Since bipolar triggers an automatic level 2, is bipolar depression an automatic level 2? Anything with bipolar is a major mental illness and it does automatically trigger a level 2.
That's the last of our questions. We'll leave it open for a minute or two. If you have any further questions on the right-hand side in the questions, you can submit them now.
Okay. We sometimes call our UMR office, they're actually your field operations office, but I renamed them about 6 years ago, so it's taken a while for everybody to understand that. We sometimes call our UMR office to clarify if a particular patient requires level 2 screen and are informed that it's not required. Should we record this informal conversation anywhere in the form? Yes, you should. Yeah. We did a training 2 weeks ago, a follow-up training with all of my field operations staff to go over to PASRR and to make sure they understood, again, everything so that they're consistent across the state in what they do. Because one of the concerns that was brought up in our meeting with FIC and HAP is that there's some inconsistency sometimes between the AAAs, what they tell you, and what field operations tell you. So I wanted to make sure for myself that my staff understood everything and what they're supposed to be telling you. And what I will tell you is if you run into an issue where you have a different answer on the same question from field operations and from the AAA, I'd appreciate it if you sent that either to Ruth Ann or into me so that we can resolve the issue. I am more than willing to talk to the Department of Aging when there are issues that surround them, both around how they're clarifying things for you and also around how they're scheduling things for you. So if you run into those types of issues, I can be a link between you and the AAA to try to get stuff done. But also if it's an issue and field operations is wrong, I want to make sure that we're corrected in what we're doing also. But yeah, anytime you have a conversation with the AAA, with field operations office, with a program office, go ahead and document that on your form or wherever you keep the PASRR on the record. How do we know the difference between major and mild? When we get the reports that does not state whether it's major depression, major bipolar disorder, major anxiety, how do we tell the difference? Well, the clarification we talked about the difference between mild depression and major depression, and same way with anxiety. If it's listed as a major bipolar disorder, major or mild doesn't matter. If it's bipolar, it's a serious mental illness that needs a level 2 done. If it's a depression, then you have to take a look at the individual and see if they meet the symptoms, or at least 5 of the 9 symptoms that we talk about in the clarification. And if they don't meet at least 5 of those 9 symptoms, then you can consider that a mild depression, and your answer in 3A would be a no. So it wouldn't meet the criteria for them to go on. And let's say it's something in 3B marked, but in 3A it would not meet the yes criteria. So do we mark yes for the mental illness diagnosis or not? If it's a mild depression or mild anxiety, you mark no. You can write that diagnosis on the line, but it is a no in that section. If it's a major mental illness, it's a schizophrenic affective disorder, it's a schizophrenia, it's a bipolar disease, anything that we would consider a major mental illness always get marked yes, and a diagnosis always gets listed. Do we do that assessment upon admission to determine that? You can make the decision to do your PASRR level 1 on the day of admission. It has to be done prior to or on the day of admission. Just remember, if you wait to do that level 1 to the day of admission and you find they need a level 2 done, you will be out of compliance. And if you're doing that and you're admitting people that way and you're not making hospitals do that level 1 prior to you taking them, then I would consider that a case in which you have decided to make your decision on how you complete the PASRR process, and it would be done incorrectly, and I will be looking to take payment back from that individual because you're not following the regulations. So be careful on that. If you're a facility that prefers to do the level 1 upon admission, that you are running that risk of having an unidentified target or an unreported target admitted to your facility, because you are not going to get the level 2 done on or prior to admission. I have nothing else. Gail, do you have anything else? Okay, what I'd like to do is I'd like to thank all of you for coming in. I'd like to thank PHCA for continuing to work with us to try to make some clarification in this process as we try to work together with them and HAP and try to resolve some of these issues. We are not going to be capable of resolving all of them. We're not going to be capable of letting stuff go because CMS is really adhering to the changes that are being made. So yes, we are going to see more individuals that need a level 2 evaluation done. And yes, it's going to slow up some discharges and admissions between hospitals and nursing facilities. We do understand that. CMS recognizes that too, and they think because of that the process is working according to how they want it to work. They're looking for us to do more level 2 evaluations. So I appreciate the cooperation that we're getting through the associations and through HAP and trying to work together with this. So I thank you for inviting us and taking your time this afternoon, and hopefully this helped out. If you have further questions, there's Ruth Ann's contact and mine, or you could also go through Gail, and Gail certainly lets us know when there's questions or issues. So again, thank you for your time, and thanks guys for setting us up.
Thanks, Randy and Ruth Ann, for taking the time to present this information and clarification on the PASRR form and process. A recording of this presentation will be made available on PHCA's website later today. Credit certificates will also be emailed shortly, along with links to the handouts, including the Q&A form document and the links that were referenced in the presentation. Thanks for your participation. This concludes our webinar.